Today's topic is Kawasaki disease. So Kawasaki disease affects only small size blood vessels. Is it true or false? This statement is actually false because it affects both small and medium sized blood vessels. So the definition of Kawasaki disease is that it's a systemic inflammatory disease that affects small and medium sized vessels, resulting in aneurysm formation. Say for an example, it causes aneurysm formation in the coronary arteries of the heart. So Kawasaki disease is the most common systemic vasculitis in children. This statement is also false because Hinox-Schönlein purpura is the commonest systemic vasculitis in children. Kawasaki disease is the second most common. So Kawasaki disease commonly affects older children. This statement is also false because it is most common before the age of 5. As any other inflammatory disease, it is more common in female children. This statement is also false. Unlike in other autoimmune conditions and other diseases, Kawasaki disease is more common in boys. So these are the 3 phases of Kawasaki disease. We'll focus on it in the next slide. It's the acute phase, first 1 to 2 weeks. Subacute phase is up to 4 weeks, and the third phase is the convalescent phase. So what are the clinical features in acute phase of Kawasaki disease? And this can be remembered by the mnemonic called crash burn. So in crash burn, C represents conjunctivitis, R is for rash, A is for cervical lymphadenopathy, S is for strawberry tongue, and H is for hands and feet swelling, and burn represents high fever. So there are 6 features: CRASH plus burn, high fever. Conjunctivitis in Kawasaki disease can be suppurative. This statement is actually false. In Kawasaki disease, the conjunctivitis is never suppurative because it's not an infection, it's an inflammatory condition. Therefore, you don't see pus in there. The conjunctivitis that you see in Kawasaki disease is bilateral, and you can see perilimbal sparing as shown in this picture. And if the patient complains of photophobia, they might also be affected with anterior uveitis, so we should suspect that. So when it comes to the rash in Kawasaki disease, it's never vesicular. So vesicular rashes are seen in hand, foot, mouth disease and varicella zoster virus infection. So in Kawasaki disease, it could be maculopapular, targetoid, morbilliform, scarletiniform, and it can be seldom pruritic. And it most commonly affects the inguinal area and the chest. The lymphadenopathy in Kawasaki disease is commonly unilateral, and in ultrasound scan you can see cluster of grapes appearance. And to say the lymphadenopathy is significant, there should be at least more than 1.5 centimeter enlargement in the scan. So what are the findings in the mouth in Kawasaki disease? You characteristically see strawberry tongue in Kawasaki disease, and you can also see dry and cracked lips with an inflamed pharynx. What are the other less frequent clinical features in the acute stage? So all these are other clinical features that you may see, but these are less common, such as abdominal pain, high drops of the gallbladder, CSF pleocytosis, sterile pyuria, arthritis, carditis, and giant coronary artery aneurysm. What happens during subacute stage? So in the subacute stage, you can see gradual resolution of fever, and coronary artery aneurysm starts to appear in the subacute stage, and you can also see desquamation of the skin, particularly in the fingers and toes. You can see a picture of that in the slide. And what are the risk factors for developing coronary artery aneurysms in Kawasaki disease. This can be asked in a MCQ. So prolonged fever, prolonged elevation of ESR or CRP, age younger than 1 year or older than 6 years, and poor response to therapy, male gender. All these are risk factors for developing coronary artery aneurysms. And Bewes lines of the fingernails may appear during convalescent phase. That is true. So these Bewes lines can be seen in Kawasaki disease. How to diagnose Kawasaki disease? When it comes to the diagnosis of Kawasaki disease, there should be fever, high fever which is persisting for 5 or more days, with 4 out of 5 clinical features that we've mentioned before, the crash. And platelet counts are high in all stages of the disease. This statement is false. The platelet count is low or normal in acute stage, and it is high in subacute stage. What are the investigation findings that you may see in Kawasaki disease? So in full blood count, you can see anemia, neutrophilic leukocytosis, hypoalbuminemia, abnormal plasma lipids, high AST, that means the liver enzymes, high gamma GT, high ESR CRP, the inflammatory markers. Platelet counts can be high, normal or low, which corresponds to several stages of the disease. And urinalysis will show leukocytosis. We mentioned that we can see sterile pyuria in Kawasaki disease. And urine culture, you don't see any organism because it's not an infection. And lumbar puncture can show CSF pleocytosis, and leukocytosis can be seen in synovial fluid analysis. And what are the 2D core findings that you may see in Kawasaki disease? You may see pericardial effusion, myocardial disease, endocardial disease, coronary artery aneurysms, and features of pancarditis. All 3 layers of the heart can be affected. So in Kawasaki disease, what you see is hyponatremia. It's not hypernatremia. And what is atypical Kawasaki disease? It's typically seen in infants with high fever. The features that you may see in atypical Kawasaki disease are fever with coronary artery aneurysm, with 3 features in crash. How to manage Kawasaki disease? A single dose of IVIG in the acute setting with a dose of 2 grams per kilogram over 12 hours. And if it fails, you can give another second dose of IVIG. And aspirin should also be considered in the treatment. So I'm not going into detail of the doses of aspirin. You can read that in the slide. Corticosteroids or infliximab are used less frequently in Kawasaki disease. That is true. Unlike in other vasculitis, in Kawasaki disease, this plays a very minor role in the treatment. And if the Kawasaki disease responds to IVIG, fever settles in 24 hours, and CRP and ESR, the inflammatory markers, drops in 48 hours. So if you are the house officer in the ward, things to look for during ward rounds are myocardial infarction, because of the coronary artery aneurysms. These children may get myocardial infarction, so they may present as excessive crying, irritability, sweating, abdominal tenderness. And you should look for features of left ventricular failure, concomitant sepsis, and bleeding, and Ray's syndrome. Ray's syndrome is should be seen because these patients are at higher doses of aspirin, which may predispose to the development of Ray's syndrome, which is life-threatening. But if you find it in the early stages, it is fully recoverable. Most cases of Kawasaki disease resolve without sequelae. This is true. These patients will not carry any complications most of the time. And what are the complications of Kawasaki disease? The complications are coronary artery thrombosis, which may lead to myocardial infarction, peripheral artery aneurysms, coronary artery aneurysms, myocardial infarction, myopericarditis, heart failure, high drops of gallbladder, aseptic meningitis, irritability, arthritis, sterile pyuria, thrombocytosis, diarrhea, pancreatitis, and peripheral gangrene. So when you are discharging a patient with Kawasaki disease, you should educate them about the possible complications, and there should be lifetime monitoring of the patient, and smoking is contraindicated because these patients are already predisposed to very vascular diseases and cardiovascular mortality and morbidity. And if the patient gets atherosclerosis, it further increases the risk, and recurrence of the disease is very rare in these children. So thank you for listening to the lecture.